Whoever's not muted, please mute. If you're on Zoom, please mute. Morikosi-chan. We have many panelists from North America and Rwanda. Some of them you know. You know our boss lady, Dr. Francoise, who is at the University of Rwanda in Sheashika. Also, Dr. Lise from King Faisal, Dr. Doris from Emergence at Sheashika, Dr. Jackson and Dr. Grace, also from Rwanda. Dr. Brendan is from Canada. He works at Dalhousie University. Dr. Vivek works at Stanford University in California. Dr. Helen, Dr. Christina, also at Stanford University in California. And Dr. Protejan and Angelique from Rwanda. They are now our colleagues. They just passed their senior exam, so we're very excited for them. And should go back. OG, can you continue to project the LRC? So
I'm doing that now.
Diego Marcosi. I mean, thank you. She's not Rwandan. Apologies. Okay, so we're going to talk today about sepsis and septic shock. Over time, the recommendations have changed. And in late October 2021, the Society for Critical Care Medicine and the European Society of Intensive Care Medicine released updates to the guidelines for the management of sepsis and septic shock. Okay, we can advance, OG. So when you sign in to the Learning Resource Center, which you all should have access to, you can have active links that will connect you to the actual guidelines, to the articles themselves. So you're free to access this, and we'll share the link with you so that you can read the guidelines yourself. But we're going to go through most of them today. There were 93 updates. So we're not going to talk about all 93, but we'll do the best that we can. We're going to have a part 1 from 9 o'clock till 11 o'clock. We'll have a small break. If we finish early, we'll have a small break, and then we'll go for part 2 from 11 onward. Part 1, we're going to talk about screening and early treatment, resuscitation, mean arterial pressure, admission to the intensive care unit, infection, source control, and hemodynamic management. So a lot to cover. Part 2 will be more around ventilation. We'll talk a bit about ARDS in that, additional therapies, long-term outcomes, and goals of care. So we're going to start the entire day, the entire morning rather, will be a case-based discussion. So we'll be talking about this gentleman. So the setting is that you're working in a district hospital. The nearest hospital with an intensive care unit is 20 kilometers away. The physician working in the emergency room calls you to come see a patient that she wants to admit to the hospital. His name is Mr. G. Mr. G is 66 years old. He's had 3 days of diffuse abdominal pain and blood-tinged diarrhea. He occasionally has nausea, but he has not had any emesis. He reports feeling weak. He has stopped eating and has not gone to work for 2 days. He's been lying in the bed. His vital signs include a respiratory rate of 29 breaths per minute. His heart rate is 108 beats per minute. Blood pressure is 103/59. His temperature is 37.5, and he's satting 91% on pulse oximetry, breathing room air. Mr. G is placed on 3 liters per minute of oxygen therapy by nasal prongs, and his SpO2 improves to 95%. Okay, so the first section, I'm going to let Dr. Francois introduce.
So the first thing is to do screening and the early treatment. We should go through the objectives you are covered through this section. So the first objective will be define sepsis and septic shock, institute screening and identify sepsis and septic shock area, understand and utilize appropriate clinical scoring system, recognize sepsis and septic shock as medical emergencies, understand mortality rate of sepsis and septic shock, understand the value and limitations of using lactate during resuscitation of sepsis and septic shock, list the 5 steps in the hour 1 bundle for sepsis and septic shock, and understand how to implement them in your settings.
So the first recommendation is that hospitals and healthcare systems use performance improvement programs for sepsis, including screening of the acute ill of high-risk patients and standard operating procedures for treatment. So at each of the hospitals in which we work, we should have protocols in place for screening patients for sepsis and for treating patients with sepsis. So this is the first recommendation.
All right, so this is our first question. What is sepsis and what is septic shock? So for those who are online, you will give your answer through the chat box, or Anna?
Yeah, so go ahead and answer through the chat box. What is sepsis and what is septic shock? And for the in-person participants, we can have one person answer. What is sepsis and what is septic shock? You can raise your hand. Clementine. For the virtual participants, please put your answers in the chat box. Okay. Sepsis is a life-threatening organ dysfunction due to dysregulated host response to infection. Wonderful. Very nice. Yeah, very nice. Okay, so we can scroll down to the answer.
So so the third international consensus provide definition for sepsis and septic shock as follow. You can just, yeah. Sepsis should be defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock should be defined as basket of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. Sepsis patient with septic shock can be clinically identified by a vasopressor requirement to maintain a mean arterial pressure of 65 millimeters of mercury or greater and serum lactate level greater than 2 millimole per liter in the absence of hypovolemia.
So in order to appropriately treat critical illness, we must first recognize when patients are critically ill. How does your hospital or clinic identify critically ill patients? So someone from the audience in person and somebody from the virtual audience should answer this question. There's no right or wrong answer. It's what does your institution do to recognize critically ill patients? How do you know someone is critically ill? How do you recognize a critically ill patient? You just look at them? Is it the way they smell? No. Well, how do you know? Go.
anesthesiologist at Mohima District Hospital. At hospital, we recognize the inpatient group triage.
Okay, and what is triage or triage? What does that include? Does it include vital signs? Does it include a history and physical exam? Diego, does it include scoring systems? Don't be shy. This is for you, for your learning, isn't it? Okay, so we'll go to the next question. Which one of the following is no longer recommended as a single screening tool for sepsis or septic shock? Can we scroll up, please, OG? There we go. So which one is no longer recommended as a screening tool? Q-SOFA, the Muse, SIRS, or NEWS? Okay, so we'll get a verbal answer from the in-person audience, and you can see we've launched a poll for our virtual participants. So answer in the poll. What is your answer from the audience? You may recognize this question, in fact. Q-SOFA. Okay, one person says Q-SOFA. Anyone else? Someone else says SIRS. Okay, we can close the poll. Q-SOFA is the correct answer. And if you scroll up to recommendation number 2, says, although a positive okay, so close the poll. And although the presence of a positive Q-SOFA should alert us that the patient might have sepsis or septic shock, it's poorly sensitive, so it may not capture all of the patients that are sick. So in fact, they made a recommendation. We recommend against using Q-SOFA compared with SIRS, NEWS, or Muse as a single screening tool for sepsis and septic shock. So this is a change, isn't it? We used to use Q-SOFA as a sepsis screening tool, and the new recommendations are telling us to change our practice. You can still use the Q-SOFA, but it may not capture all of the patients that are sick. So it mentions a few other screening tools. Specifically, it says SIRS, NEWS, Muse. So the next question is, how do you calculate a Q-SOFA, a NEWS score, a Muse score, or SIRS? How do you calculate these things? I don't remember all of these things on the top of my head. I actually have to look them up as well. The good thing is there's some clinical calculators that you can access online or as an app on your phone that will help you calculate these things. So if you click on the question box on the Learning Resource Center, it will take you to a very useful site called MD Calc. And if you type in the search box on MD Calc, Muse, NEWS, or Q-SOFA, you can enter in parameters for your patient. So for example, OG, can we type in Muse, W-E-W-S? Muse. E, yeah, perfect. And then if you click on Modified Early Warning Score or Muse, it will show you can enter the systolic blood pressure, the heart rate, the respiratory rate, and the temperature, and the AVPU score. And this website will automatically calculate for you the Muse score. Okay. We can go back to the LRC. So just know that this resource is out there for you. At the end of today, I'll give you all this information, okay? So don't feel like you need to write it down because we'll give it to you at the end of the day. Okay, so although the presence of the positive Q SOFA should alert us, it's poorly sensitive. Okay, so we're no longer using it by itself as a screening tool. Okay, go ahead.
So the next question about our case is, what are your first steps in managing Mr. G? That's 45 seconds.
He already had some oxygen. He's a little bit tachycardic. What else would you do? So he had a respiratory rate of 29. His heart rate was 108. Blood pressure was normal at 103/59, and he was 91% on room air, and we put him on some oxygen. Is there anything else we would do?
We've got some answers in the chat box.
Okay,
Right?
let's see what
Yeah.
our virtual
Yeah.
audience is saying.
So unfortunately, they sent to me directly. Delha said,
Taki, no problem.
start him on fluid resuscitation.
Great.
Then Simon
So-
said, start antibiotics.
Perfect. Okay, so some people are starting to want to help Mr. G by giving him some fluids and starting antibiotics. I think those things are certainly reasonable first steps. I think the first thing that I would do is make sure that he has more frequent vital signs checked. So if we're checking his vital signs twice a day, perhaps we need to check it more often. So just having an increased vigilance is important. Okay, so we can scroll past that. OG, thank you. So let's look at the map for a second. Okay. So in 2017, there was a global burden of disease study that looked at the incidence and mortality of sepsis and septic shock across the entire world. And you can see by looking at the map that those places that have fewer resources carry a larger portion of the burden. So I think it's important for us to be aware of the numbers and the differences with resource constraints. So it's important for us to recognize that early recognition of sepsis and septic shock, as well as early intervention, is going to be very, very important for the outcomes of these patients. We can scroll forward. Oh, we already did that.
So our next question is, what diagnostic and laboratory investigations will you obtain for Mr. G?
Somebody from the in-person audience, would you do any investigations or laboratories? There you go. Good. So a full blood count, electrolytes, urea and creatinine. Anything else? Blood cultures. Good.
Yes.
Anything else?
About imaging, you can also get X-ray.
X-ray of what? His foot?
Which X-ray?
Which X-ray?
X-ray.
chest X-
Abdominal X-ray.
There you go. Those are very good. Okay. Anything else you want? There's Gideon, one more. Okay, we're going to take one more question and then move on.
We do make left X-ray on the urinalysis.
Perfect. A lactate level and a urinalysis. So let's scroll up to the hour one bundle. Take it away, sister.
So from the Surviving Sepsis campaign, there is a combination of like 5 elements we have to be sure that we cover in the first hour when from when the patient at your facility. So the first thing is measure lactate level and remeasure lactate if the initial one was elevated, which means above 2 millimeter of millimole per liter. So the second step should be obtaining blood culture before administering antibiotics. The fluid as rapid as you can, 30 mL per kg, crystalloid for a patient who is having hypertension or a patient who is having lactate which is above or equal to 4 millimole per liter. The fifth step is vasopressor if hypertension during or after fluid resuscitation, in order to maintain the mean arterial pressure above or equal to 65 millimeter of mercury.
So there we go. Let's stop on that recommendation number 3. So for adults suspected of having sepsis, we suggest measuring blood lactate. So just to review the things that you're supposed to do very early once you suspect sepsis is draw blood cultures, start antibiotics. Okay, you want to draw the blood cultures because you want to see what the source of infection is, right? Start the antibiotics to treat the infection. If somebody's blood pressure is low, they're hypotensive, which is defined as a MAP less than 65, then you want to give a fluid bolus. You want to draw the lactate level, and if it's greater than or equal to 4, you'll give fluids. It's really important to find the source of the infection because that's why the person is sick, isn't it? Okay, let's go to the next case update and see how Mr. G is doing. Dr. Francois.
Yes, please. So Mr. G now is report that he has history of hypertension but does not take medication, no previous surgeries. He's married, retired, 3 other children, does not smoke or use alcohol. He's awake, alert with no facial neuro exam. The Glasgow Coma scale is 15 out of 15, still awake. So regular heart rhythm, but he's tachycardic. The breath sound are clear in both lungs. Abdomen is soft but slightly tender to palpation, especially in the lower quadrant. No rebound or guard tenderness. Guarding. River edge is not hurt. Extremities are cool. Capillary fill time is 3 seconds. No edema. The height is 181 centimeter. Weight is 75 kilogram. So the emergency medical doctor start an 18 gauge peripheral IV line to start a crystalloid infusion. Lactate acid was taken, full blood count, and complete metabolic panel. Transaminase and coagulation panel has all of them been taken and sent to lab. A portable chest X-ray was also ordered. Anna?
So another recommendation number 4, is that sepsis and septic shock are medical emergencies. We recommend that treatment and resuscitation begin immediately. This is a best practice statement. So in your facility, as soon as you suspect sepsis and septic shock, you need to act immediately and monitor the patient very closely and take these steps. So the next section is initial resuscitation, and I'm going to turn it over to Drs. Grace and Jackson to introduce the objectives.
Okay, thanks, Arana. We now going to talk about initial resuscitation with objective to list out. Dr. Grace is going to go through. Next. Next slide. Hope you all remember the
Okay. Okay, just remote learner, can you hear us? Look in your box for the answers. OG, can you hear us?
I can hear you, but before you, the doctor that was speaking, I think Dr. Jackson, we could barely hear him, but you, I can hear.
Can you hear us?
So just go ahead and ask the next question.
So with the case update after the initial resuscitation that has been done. So here is one question about Mr. G's status. Mr. G weighs 75 kg. And we are asking ourselves how much steroid fruit should we be given to Mr. G during initial resuscitation.
And it looks like most of the people virtually answered D, but some answered A, B, and C. So can we just talk about where we get the number 2250?
Thanks from both answers, and the answer is D. Now we're gonna talk why D is the best answer. From the recommendation number 5, for patients with sepsis-induced hypoperfusion or septic shock, we suggest that at least 30 ml per kilo of IV crystalloid fruit should be given within the first 3 hours of resuscitation. That's the reason why to a 75 kg times 30 ml per kilo will equal to 2,250 ml.
So OG, I think we need to scroll up a bit. Up.
Did I end the current poll?
No. I want her to scroll up. OG, good. Scroll up, please, back to where we were.
Oh, okay.
Yeah, okay. And then down a little. Okay, so next question. According to the Surviving Sepsis Campaign 2021 updates, which one of the following is an acceptable and recommended fluid for resuscitation? So scroll up to that question, please, OG. Okay, so now from both the in-person and virtual audiences, according to the Surviving Sepsis Campaign, which one of the following is an acceptable and recommended fluid for resuscitation? A is gelatin synthetic colloid, B, normal saline, C, albumin, or D, hydroxyethyl starch. So from the in-person audience, we have an answer.
It's been normal saline.
Okay, we have an answer for normal saline. In the virtual audience, the remote learners are also saying normal saline, normal saline. Okay, let's go to the next. Oh, and on the poll question, the majority of people answered normal saline, but a few people answered albumin. Okay, this is getting very interesting, so pay attention. Next recommendation. Scroll up, OG. In the face of inconclusive effect on mortality, higher costs, the panel issued a weak recommendation against the use of gelatin. So gelatin is not the answer. For decades, the administration of normal saline has been common practice, but potential adverse effects that include hyperchloremic metabolic acidosis, renal vasoconstriction, increased cytokine secretion, and concern about acute kidney injury have led to increased interest in chloride restrictive solutions known as balanced or buffered solutions. Subsequently, a network meta-analysis of 14 randomized controlled trials of patients with sepsis showed an indirect comparison that balanced crystalloids were associated with decreased mortality compared to saline. What does this mean? It means that when we give lots and lots of saline to patients, we're actually causing some problems. The high chloride content of normal saline can lead to a hyperchloremic metabolic acidosis, which would worsen the sepsis picture. There's also an association with increased acute kidney injury and increased release of cytokines. So we are no longer recommending saline as the primary resuscitative fluid. We do recommend, however, crystalloids as the primary resuscitative fluid. So we need to understand what other types of balanced crystalloids do we have access. Some common other balanced crystalloids include Ringer's lactate, sometimes called lactated Ringers. Other things include plasmolite and Normasol. So whichever of these fluids you have in your institution, it's preferable for you to use that solution instead of normal saline. So this is a change in practice. It's also, in some regards, a propagation of a very, very, very long debate. Everybody's always debating about what types of fluid and how much to give. So in the 2016 guidelines, there was also a strong recommendation against using hydroxyethyl starch, and that recommendation is the same. Okay, so this is something a little bit new that we'd rather not use the saline. So the formal recommendations from the update article is that with adult patients, we recommend using crystalloids for fluid therapy. they recommend using balanced crystalloids instead of normal saline. And if you have to give large volumes of crystalloid, then you can use albumin. So albumin is also a recommended fluid if you have to give so much of the crystalloid, okay? We recommend against using starches and against using gelatins. So this is something for us to pay attention to. Questions? The right answer is albumin. If you go back, can we go back to that question, OG? Scroll up. Okay, so we lost our connection. Apologies. Let's get started again where we left off. So the correct answer is albumin. Okay, so saline is the incorrect answer. Still waiting for the LRC to project. Let's wait. We still can't see the LRC. Sorry, apologies for the technical difficulties. Okay, so we have a question about maintaining blood pressure with fluid resuscitation, isn't it? So your initial resuscitation is with fluid. That fluid should be a balanced salt solution such as lactated ringers, plasma light, or normal salt, not saline because of the complications from saline. However, if you've given multiple boluses of lactated ringers, you can also add albumin, but it's not the first line choice, okay? And you're gonna fluid resuscitate. The point of fluid resuscitation is to increase perfusion to the cells, okay? So blood pressure is one way Okay, so we've reconnected, but still cannot see the screen.
Yeah.
Okay, thank you. Sorry for that disruption. We're going to hand over to Dr. Jackson now.
Thanks again. I hope for the online team are hearing. So we are still resuscitating this patient, and we're going to head to the second question. It is asking which one of the following is considered a dynamic measure of responsiveness to resuscitation. Both the online team and the in-person audience, you can answer.
So we have a poll for the remote learners, and we have someone answering in person as well.
So the answer is E, all the above are used.
Okay, so an in-person audience member said E, all of the above. It looks like 57% of the virtual learners said the same thing. Some people answered only stroke volume, only passive leg raise, or only pulse pressure variation. Okay, Jackson.
Thanks, Anna, for helping. And thanks to the audience for giving the right answer D. We're going to hear from the E, sorry. We're going to hear from the recommendation 6, 7, and 8.
About the recommendation number 6, for adults with sepsis and septic shock, we suggest using many measures to ensure suspension of physical intervention. The main parameters include response to passive rise or reflux using fluid volume, or where available. For others with sepsis, during and then recommendation number 8, for adults with sepsis, septic shock, we suggest using adjunct measures of perfusion.
If I may just share one remark about lactate. So when we measure the lactate, when the patient is admitted, we measure the lactate very early, and if it's elevated and we fluid resuscitate appropriately, we should see that lactate go down. Okay, so you should draw another lactate after the resuscitation to ensure the lactate has gone down. One clinical situation where lactate does not go down very quickly and may stay elevated is in patients who have end-stage liver disease or cirrhosis. It's just something to note. They clear their lactate very slowly, but most other patients, you'll see the lactate go down very quickly.
Note that all measures will not work in different settings. Like when you are at Cape Anatomy Hospital, it will not work for half the lactates. Yes. So in doing so, to resuscitate your patient, you may use leg rise, or you may use capillary filter to know if the patient is really resuscitated somewhere. Thanks.
And that was actually a question earlier in the session from one of our remote learners. If you don't have lactate, which is very common, how do you measure that you're resuscitating the patient well? And that's where we talked about when Dr. Jackson saying that the dynamic measures of resuscitation are more important. So passive leg raise, pulse pressure variation, if you have those things. So if you don't have lactate, use those other things to assess how well you're resuscitating your patient.
We have the next slide to
2 years.
oh, to ourselves again. So with the case update, Mr.
We
G
have one
receives-
question. Hold on just one second. Oh, okay. Keep going, Jackson.
For the English update,
Okay.
Mr. G receives 2,250 mils of IV crystalloid over 2 hours. Blood cultures, urine culture have been ordered. Now lactate is 4.5 millimole per liter. White cell count 17. Serum creatinine 213 micromole per liter. About vitals, respiratory rates are 28 per minute, heart rates 115 beats per minute, blood pressure 99 over 46, and temperature of 438.5 centigrade degrees, and an SpO2 of 94% on 3 liters per minute by nasal glands. And after reviewing his vital signs, what's the next most appropriate intervention and therapy to improve the outcome for Mr. G?
So his heart rate went up from 108 to 115, and his blood pressure went down to 99/46. Respiratory rate is about the same. Lactate is greater than 4. So what would be the next step?
Yeah, well, we can't talk about sepsis without recalling what is mean arterial pressure. Can you move upwards, please? Yeah. So this section, we should be able to calculate the mean arterial pressure when given systolic and diastolic blood pressure values, and recite the goal for MAP during hemodynamic support during septic shock. If you remember well, the last blood pressure that was
99/46.
yes. So what is Mr. G mean arterial pressure? Take a few moments to calculate the MAP.
So we want to calculate Mr. G's mean arterial pressure. His systolic pressure is 99 and his diastolic is 46. So the answer is 64. His MAP is 64. So good job in the chat box. Simon and Justin both came up with 64. So can you please turn off your microphones and mute unless you're speaking?
Sorry, Dr. Ann, we have a question. Someone is
Thank you
asking.
for calculating the appropriate MAP. Now, assuming Mr. G has, which one of the following values is the most appropriate blood pressure goal for most of patients in septic shock requiring vasopressor agent? A, systolic blood pressure above 100, B, MAP above 60, C, systolic blood pressure above
Next question, please.
Assuming he has been adequately volume resuscitated, will you start Mr. G on vasopressor agent? Audience, let's first get from the pool.
So the next question is yes or no. Assuming he's been adequately resuscitated, would you start him on vasopressor agents? Virtual audience is saying yes, 100% so far. Anybody would not start pressors?
So it's obvious that this patient requires vasopressor, and indeed he requires to be admitted to intensive care unit. So we are going to look at if patients are going to ICU, what should we be prepared for? What should we say when handing over? So with that.
So, OG, can we scroll up, please?
Yeah.
So the appropriate value for blood pressure is a MAP greater than 65. So we're going to move to the next one. Next to the next section, please. Admission to intensive care.
It seems I was fast. Yeah. So with regard to admission in ICU, we should be able to list the goal time frame in which patients with sepsis or septic shock should be transferred to an ICU. Then list at least 5 considerations when transferring critically ill patients, be it inter-hospital and intra-hospital. So as a recommendation, what do I do is that for adults with sepsis or septic shock who require ICU admission, we suggest admitting these patients within 6 hours.
Thank you, Doris. Moving to the next slide. What resources is the patient most likely to require during his illness? And how will you arrange transfer to ICU for this patient? Let's first see how our audience respond from the pool.
Let's stay on.
Stay on the question, please, OG. So the question is, what resources is patient most likely to use, require during his illness, and how would you arrange transfer? So right now, Mr. G is hypotensive. We have fluid resuscitated him, but his MAP was remaining 64. So we started him on vasopressors. He's on oxygen by nasal prongs, isn't he? So what considerations do you have for transferring this patient, and what do you anticipate he's going to need during his hospitalization? Those are the questions. Close monitoring for sure.
Yeah, let's get also some answers from the team here.
Our colleague, Dr. Dalla, is answering all the questions. You need to keep up with them, please.
Anything else we need besides close monitoring? Yes, sir.
This is an emergency. During the transport of patients, you need close monitoring. Specifically, oxygen. You need the oxygen source. The patient. And also, we have to make sure that the patient is able to make sure the patient where they are assisted during transport.
Yeah. All those are commendable answer. Anyone else so that we capitulate? Other consideration? Okay, so there are available online checklists that we may use, but before
Can you click on that question
Box, please. Go back to the question and click on it, please.
there is a link.
The resources, there you go, that one. Thank you.
Yeah, so as you can see, this is one of the checklists that can be used. There are preparation that needs to be done before transferring the patient. You need to prepare. There are some preparation that needs to be considered. Then there is patient check that needs to happen. And then there is what you need to check for before you move to the next hospital. So as part of the preparation, you need to see if the patient is fit for transfer. Have you contacted the receiving facility about the bed availability, where all the notes printed out and all the treatment plan well noted, and so many other considerations you need to look for before preparing to transfer the patient. And then you can check the patient. Is this patient fit for transport? Regarding airway, is it safe and secure? Do I need to interview? Very well secured. How are the hemodynamics? Did I check my glycemia? Do they need more sedation? You need also to check if the monitoring of that patient is working. And so many, like you will do a full examination of that patient, making sure that you don't get surprised during the transport. And then before transfer, ensure that the receiving facility is ready, you have everything ready. Then there is a checklist you need to check before you move. Do I have enough staff? Like, do the staff know each other? Is oxygen available in the ambulance? Are the infusion being run in the ambulance? Do we have numbers of the doctors or the receiving team? So you can refer to this online checklist and customize them, and this is before you transfer. Now, when you reach the receiving facilities also, there are available checklists that you may use. Again, solution, but generally, there are considerations you have to do before moving patients. consideration during the movement of the patient from the ambulance to the bed or to the receiving facilities, and then the handover. So before moving the patient, you have to make sure that the receiving team and the transferring team know each other, and you have clear roles: who will control the airway, who is going to be the supervisor, who is going to be in charge of ventilator and tubes. And then after you map how you move the patient from the ambulance, then you move the patient, making sure all the infusions, all the monitors are transferred. And after you've settled the patient in the receiving unit, then you will be ready for the handover. And the handover has to be extensive, and all the team involved in the transfer and in the reception have to be involved. You have to give the full history, if there was any problem regarding airway and ventilation, if what are the tubes and lines that the patient have, what is the allergies of the patient, and all other procedures that you have done. You can again refer to this checklist. And again, these are aid memoirs. They will help you not forget anything, but you have to remember that all institutions are different. So we check online and customize them to our institution.
Thank you, Liz. I think that was thorough explanation. Can we scroll? So, yeah, there is a case update there, and we should all remember our setting, that they are different at some point. So you're working in the rural district hospital as Zapso, and on the other end of the country, and yeah, so we should know the local resources that are available. We should know how to triage patients within the facility, how to stabilize a patient prior to transfer. We need to identify and prepare risks of transferring the patient, know how to implement smooth and safe transfer of the patient to a higher level of care. And remember, safety first. We need to practice good preparation and communication with transferring team. So we have been talking about sepsis and we still continue, but we are moving to the infection on its own. And the following section is going to be with Dr. Angelique and Dr. Protogène. But before they continue, let us go through the objectives. So we should be able to recite the time frame in which antibiotics should be given to a patient suspected of having sepsis or septic shock. Understand when antibiotics should not be given to a patient. List the appropriate use of procalcitonin to guide the management. List at least 4 risk factors for infection with MRSA. List at least 4 risk factors for infection with MDR organism. List 4 risk factors for infection with fungal organism, and then write an order for prolonged or continuous infusion of beta-lactam antibiotics. Over to you, Dr. Angelique and Protogène.
For introduction. So continue with recommendation 11.
alternative cause of illness is demonstrated or strongly suspected. So we continue with question. Would you give Mr. G antibiotics? We need the audience to respond if yes or no.
Yes.
Thank you. The answer is yes. I see the people is online, many of us is responding if yes. Keep scrolling.
Everybody's answering yes.
Yes.
Okay.
Keep moving slide.
Yeah, so we can end the poll and move to the next slide, please.
So, thank you, Angelique. Let's continue with the case update. Mr. G has received IV fluid with crystalloid solution, initially at 30 ml per kg, followed by an additional 500 ml until his capillary fill time decreased to less than 2 seconds. He was started on noradrenaline at 10 mics per minute to maintain his MAP above 65 millimeters of mercury. The emergency room physician has also ordered a CT of his chest, abdomen, and pelvis to look for the source of his presumed infection.
Okay. The next question, you ask the emergency room physician to administer antibiotics to Mr. G, but she stated that she is waiting for procalcitonin result from the lab. How do you respond? We need the audience to respond.
Do you wait for procalcitonin before starting antibiotics?
Thank you. The answer is no. We are not need to wait the procalcitonin before initiation of antibiotics. So with no apparent benefit and known costs and the limited availability in some setting, including low middle income countries, the panel issued a weekly recommendation against using procalcitonin to guide antimicrobial initiation in addition to clinical evaluation. Recommendation 16, for adults with suspected sepsis or septic shock, we suggest against using procalcitonin plus clinical evaluation to decide when to start antimicrobials as compared to clinical evaluation alone. The next question, is Mr. G at risk of MRSA infection? MRSA, methicillin-resistant Staphylococcus aureus infection. We need the audience to respond if yes or no.
So MRSA is a drug-resistant bacteria, and certain patients are at risk.
And certain patients are not at risk. So we need to determine
This patient is at risk. If he was at risk for MRSA, we would have to start with vancomycin, a specific antibiotic for MRSA, or linezolid. So we need to determine whether we start with antibiotics, and that's determined by these risk factors. So the remote audience is saying 6% at this point are saying yes, and 24% are saying no. So we'd like to hear from the audience.
So
So it seems like the audience is split. Some people say yes, some people say no. So let's go through and see if we can find the answer.
Actually, some risk factors for MRSA includes patients who are hospitalized, and especially those patients in ICU, and those patients who are having indwelling catheters, meaning central lines, meaning Foley catheters, those patients who are in the nursing homes, and some patients who are having wounds, and those patients who have been spending long time on
So does Mr. G qualify for one of those risk factors? I would actually say no.
He's not from a nursing home. He doesn't have indwelling devices that have been there for days. Another important thing is to know the antibiogram of your hospital and your intensive care unit. If you have a high incidence of MRSA infections, then your patients are more likely to contract that while in the hospital. But at this point, just looking at this patient who just was been sick for 3 days, came from a district hospital, he's not at risk for MRSA according to those definitions.
17 recommendation for adult with sepsis or septic shock at high risk of methicillin resistant Staphylococcus aureus. We recommend using an empirical antimicrobial with MRSA coverage over using antimicrobial without MRSA coverage. For adult with sepsis or septic shock at low risk of MRSA, we suggest against using empirical antimicrobial with MRSA coverage as compared with using antimicrobials without MRSA coverage.
What is the problem with using antibiotics unnecessarily and not targeting? What's the problem that you encounter? Right, that's right. You get antimicrobial resistance.
So let's go to the case update. So Mr. G has diarrhea, as you have heard before, weakness, anorexia, and abdominal tenderness. He feels tired and states that his abdominal pain is worsening and is mostly localized to the lower quadrants. He has fever, tachycardia, tachypnea, hypotension, and hypoxia. Lactate is elevated, and the white blood cell count is elevated. Serum creatinine is elevated. His chest X-ray is clear, but with small lung volumes. Chest CT, abdomen, and pelvis is still pending because the machine is broken. Mr. G now, as you know, this happens sometimes. So Mr. G now has improved blood pressure with the MAP above 65 millimeters of mercury after IV fluids and with noradrenaline infusion running. His SpO2 is stable at 95 to 97% on oxygen by nasal prongs, set at 3 liters per minute. He has now received 2 grams of ceftriaxone, and at conclusion, he has a septic shock with presumed abdominal source of infection, and we are planning to transfer to a higher level of care as soon as possible. The nearest hospital with an ICU has accepted to receive the patients. The patient and the family agreed to transfer. The insurance includes coverage for ambulance services. The ambulance will arrive in 15 minutes to pick Mr. G up and transport him to the tertiary hospital. The next question is Mr. G at risk for multi-drug resistant organisms? So you can answer for in-house and online. So A is yes, B is no. And as you know, in settings, sometimes you find the germ that are resistant to many of our antibiotics we are using. So we need to know which patient are at high risk. So let's, Angelique, help us to revise some risk factors for multi-drug resistant organisms. I see from the pool it's 50-50. Interesting, 50-50.
Then,
That's a good point of learning. 50% think it's one and 50% think it's the other. Let's see if we can find the answer.
Yeah.
And sometimes
Correcting the practice, like the usual daily practice, right? So it's really interesting.
so this patient, the patient who has underlying comorbidities such as diabetes mellitus, patient who has malignancy, patient who has chronic kidney disease, the patient who stay longer in the hospital or prolonged duration in the hospital, or the patient who has enduring catheter, including central venous catheter, Foley catheter, ETT, frequent contact with many patients, the people who are caring many patients in the hospital, and the patient who are exposing to many healthcare personnel, all those are prone to multi-drug resistance.
So now how would you answer, yes or no?
Mr. G is coming in from home. He's not coming from a nursing home. He's not been in the hospital. None of his family members are medical workers. He's not had indwelling catheters for a long time. I would say he's not elderly.
Been exposed to other patients.
He's not been exposed to other patients. He's not been on antibiotics previously. He has no risk factors for multi-drug resistant organisms because he's coming in from home. Multi-drug resistant organisms are commonly seen in the hospitals, in nursing homes, in some sort of care provision setting with lots of medical workers that are exposed to these bugs. And these bacteria, you don't contract them at home, okay? So Mr. G is not at risk. Would you agree, Angelique and Partisan?
Yes.
Let's see the 19th recommendation from the Surviving Sepsis campaign. For adults with sepsis or septic shock and high risk for multi-drug resistant organisms, we suggest using 2 antimicrobials with gram-negative coverage for empiric treatment over 1 gram-negative agent. 20th recommendation for adults with sepsis or septic shock and low risk for multi-drug resistant organisms, we suggest against using 2 gram-negative agents treatment compared with 1 gram-negative agents. 21st, for adults with sepsis or septic shock, we suggest against using a double gram-negative coverage once the causative pathogen and susceptibilities are known.
So if I may just say a word here.
In many practices, providers will suspect that a patient has resistant organisms because of their antibiogram. And so sometimes with concern for things like Pseudomonas, they'll start 2 antibiotics to double cover for specific organisms. And what these guidelines are saying is don't do that, because unless you know your organism is resistant and needs that double coverage, you're just going to create more resistance in the bacteria. So don't double cover unless you know that the organism is resistant. Does that make sense to everyone? Okay, perfect.
Thank you, Anna. So as we are going through the potential risk for germs from the patient. So let's see this question. Is Mr. G at risk for fungal organisms? The answer is yes or no. I have one answer, which is no, from the in-house.
Yes or no?
No. Yeah. Yes. Let's review some risk factors for fungal infection.
Some risk factors for fungal infection is including for immunosuppressed patient, like HIV patient, patient who undergo transplantation, patient who come from oncology, patient who have prolonged neutropenia, the patient who is in menopausal status period. All those is some risk factors of fungal infection.
So as most of you answered, the answer is no. As Mr. G doesn't have these risk factors, no immunosuppression, no comorbidities predisposing him to immunosuppressions, and no indwelling catheters. And so I see from the pool, most of the people answered no. So 22nd recommendation for adults with sepsis or septic shock at high risk of fungal infection, we suggest using empiric antifungal therapy over no antifungal therapy. 23rd, for adults with sepsis or septic shock at risk of infection, we suggest again antifungal therapy. From this surviving sepsis campaign, we make no recommendation on the use of antiviral agents. So from here we introduce Brandon for the source control. Thank you.
Thank you very much. So the next step is about source control. So we can just scroll down a little bit there. OG.
So maybe you can read this quote about the viral infections. The viral infections encompass pandemics are rarely the primary cause of sepsis. In a recent large international point prevalence study, viruses were documented in less than 4% of infections. Due to the rapidly changing position related to antiviral therapies in critically ill patients presenting with severe acute respiratory failure, this panel decided not to issue a recommendation on antiviral therapies and to refer the reader to more specific guidelines. Recommendation 25, for adults with sepsis or septic shock, we suggest using a prolonged infusion of beta-lactams for maintenance after initial bolus over a conventional bolus infusion. So the next question, Mr. G has received 2 grams of ceftriaxone as his initial antibiotic therapy, and the dosing interval is every 24 hours. How can you write the order for prolonged infusion?
So I'm gonna actually move us forward because we're running a little bit behind time. So the recommendation is that
When you write your order for beta-lactam antibiotics, then instead of giving it over 10 minutes or however you normally would give it, you actually run it in slowly using infusion over like 8 hours. So this is a recommendation. It's still, even in my setting, has not been adopted into practice, except for a few clinicians like me. I think I might be the only one doing this. So just know that you can run your antibiotic in very slowly and have it almost continuously throughout the day. And that keeps your level of antibiotic in the blood a little bit higher. So that's a recommendation for this. So let's go ahead and move on to source control, just for the sake of time.
Wonderful, thank you very much. So the next tip here is about source control. So we're going to be talking about the methods and timing of source control, the appropriate use of IV access in patients with sepsis and septic shock, and appropriate prescribing durations for antimicrobial agents. So OG, if you can just slide down a little bit to the next section there. Another case update. I'll just begin to read it. Mr. G has been transferred to the tertiary care center by ambulance. He remains stable during the transport on nasal cannula and on a low-dose noradrenaline infusion. He is now admitted to the ICU. He is on continuous monitoring, including pulse oximetry. He remains alert and awake, but his abdominal pain is worsening, and he now has had 2 episodes of emesis. He is on IV fluids. He has received ceftriaxone 2 grams. His vital signs include a respiratory rate of 29, heart rate of 118, blood pressure of 99/42, a temperature of 38.5, and a SAT of 93% on 3 liters nasal prong. His CT chest, abdomen, and pelvic without contrast was performed. The chest was clear lung fields with decreased lung volumes by basilar atelectasis and small pleural effusions without a pericardial effusion. The liver was normal. The gallbladder was slightly enlarged with sludge, but with no wall thickening or gallstones. The spleen was normal. The pancreas, adrenals, and kidneys are unremarkable. But in the GI tract, there was multiple mildly distended small bowel loops containing air fluid levels within the mid to distal small bowel. There is gradual tapering distal to the level of the terminal ileum with no definitive transition point identified. Air fluid levels throughout the colon suggestive of diarrheal illness. There is colonic wall thickening in the left lower quadrant without emphysema or surrounding inflammatory changes. No findings concerning for abscess. A normal appendix is identified in the right lower quadrant. The bladder was unremarkable, the aorta was normal in caliber, and the bones and soft tissues were unremarkable. So recommendation 27 is that for adults with sepsis or septic shock, we recommend rapidly identifying or excluding a specific anatomical diagnosis of infection that requires emergent source control and implementing any required source control intervention as soon as is medically and logistically practical. So our next question is, how would you get control of the infectious source of Mr. G? Is there anyone from the in-person audience that has any suggestions?
Does he need something removed? We go to CT scan and they'll do chest, abdomen, pelvis, looking for a discrete source of infection that we can intervene upon. Did a CT show any abscess, any perforation, anything like that need surgery for?
So for those watching at home, we have thumbs down saying that no, he does not require surgery. His findings on CT are most suggestive of a diarrheal illness, so he's probably going to be okay with bowel rest, resuscitation for his hypovolemia, and antibiotics to target the most likely pathogen. So our next recommendation is recommendation 28. And that is for adults with sepsis or septic shock, we recommend this is a separate one. We recommend prompt removal of intravascular access devices that are a possible source of sepsis or septic shock after other vascular access has been established. So in our patient, he does not have a central line, but there are times where a central line would want to be removed. So if a patient has a long-term indwelling catheter, like a PICC line or a hemodialysis catheter, and you think that this could reasonably be a source of the sepsis, and you have the ability to get other access to continue giving IV fluids and IV antibiotics, it may be reasonable to take out that central line in order to help get source control. But in other patients, that's just not feasible. If they're dialysis dependent, as an example, you might need to get control through antimicrobial management first, and then replace the central line once they're through the septic shock period. Do you agree with that, Dr. Anna?
I would agree with that. And in this patient specifically, Mr. G is just coming into the hospital. So even if we put a central line in, we're not just going to take it right back out, are we? Because so you want to treat the infection that was causing the sepsis. If he were in the hospital for a long time and he had a central line, then we would consider that as a source of infection, but not a new line. A new line is not the source of infection. Just want to take 1 second to go back to the CT. The CT showed some dilation and inflammation in the colon, but it did not show an acute obstruction. It is most likely consistent with diarrhea and an ileus. Neither of those are surgical indications.
Okay, so now we have a case update for this patient. A surgeon is consulted, but states that there is no surgery indicated and recommends bowel rest and resuscitation for hypovolemia, similar to what we discussed. Meanwhile, the laboratory calls and has a couple updates. The blood cultures for this patient returns with gram-negative bacilli. The urine culture results are pending, but the initial urinalysis is unremarkable. And the respiratory culture is still pending. So with that, we'll move on to our next recommendation, number 29, which states that for adults with sepsis or septic shock, we suggest daily assessment for de-escalation of antimicrobials over using a fixed duration of therapy without daily reassessment for de-escalation. Can we move down to the, so that we can see the question? Or just start reading it. Okay, so our next question, assuming his hospital course improves over the next few days, for how long would you keep Mr. G on antibiotics? Anyone here or our virtual audience, please feel free to type answers in the chat.
How many days would you keep them on antibiotics?
Okay, I'm hearing a couple saying 7 days. Yeah, and Simon in our chat also responded 7 to 10 days, as did Dr. Tala. So good. So with that, with our next recommendation related to this question, for adults with an initial diagnosis of sepsis or septic shock, an adequate source control where the optimal duration of therapy may be unclear, the latest recommendation is to suggest using procalcitonin and clinical evaluation to decide when to discontinue antimicrobials over clinical evaluation alone. And
before we go on there, I just want to make a couple comments about the duration of antibiotics. There's some varying answers in the chat box. Some people say 7 days, some people say 10 days, some people say switch antibiotics. The answer is different depending on the source of infection. So if someone comes in with a pneumonia, we now know and have evidence from studies that you can treat for 7 days and then stop your antibiotics. This patient isn't coming in with pneumonia. He's coming in with septic shock from an abdominal source, likely a diarrheal or a GI infection. And he's very sick. He's in septic shock. He's now been fluid resuscitated and we started him on more adrenaline. So in this case, in particular, I would probably continue his antibiotics for a bit longer. So I would probably do 10 to 14 days, depending on his clinical picture. So again, when you have somebody who's very sick, you need very vigilant, close monitoring, and that's not just for worsening, but also for improvement. You want to see if your patient's improving. So if your patient starts to improve after 5 to 7 days, then you can start thinking about de-escalating your antibiotics. Procalcitonin is not available in all settings. Even in our country, we don't have procalcitonin everywhere. So if you have it available, it can be helpful in determining whether the patient has responded to the antibiotics or not. When procalcitonin is not available, then use your clinical picture to determine if the patient is improving.
All right, thanks, Anna. Let us move to hemodynamic management discussion about our patients. So our objectives will be to be able to name the first line vasopressor agent for septic shock, list 2 alternative vasopressor agents that are recommended if the first line agent is not available, list vasopressor agents associated with high incidence of dysarthmias, describe when vasopressin should be used, list 3 agents that can be used for septic shock with cardiac dysfunction. So we'll move to our next question, which is which of the following vasopressor agents is the least likely to precipitate dysarthmia? So we have for A, vasopressin, B, dopamine, C, epinephrine, then levosimendan, yeah. So we'll get answers from the audience and the rest will give their answers on chat box, right?
Yeah, the poll.
Yeah, sure. And then poll, yeah.
So which one do you think is least likely to cause dysrhythmia? Okay, so people in the in-person audience are saying A. Anything else? Any other answers? Anybody disagree? So it looks like our remote audience has a bit of a debate. They think maybe A, maybe B, maybe C, maybe D. The answer is actually A. Vasopressin is the least likely to cause dysrhythmias. Dopamine, epinephrine, and levosimendan are all associated with abnormal rhythm generation, especially at higher doses. So vasopressin is least likely to precipitate dysrhythmia.
All right, next. OG. Yeah, some update of the case. Mr. G has a map of 60 despite 40 mics per minute of noradrenaline. His fluid status seems avolemic after IV fluid resuscitation. Unfortunately, he has greater tachypnea with a respiratory rate of 30, and his oxygen requirement has increased to 8 liters per minute by 30 minutes. So our next question, what steps will you take to better manage Mr. G's hemodynamic status? So we have this.
Let's see that next.
Oh yeah, so
Yeah.
just go with. this
Okay, so
question.
currently, go back to the question, please, OG. So currently, we have Mr. G fluid resuscitated. He's on noradrenaline. His oxygen requirements are increasing. What can we do now? Because his MAP is still 60 and our goal is greater than 65, isn't it? So what can we do next? We can recheck his fluid status, right? We can use our dynamic measures. We can do a passive leg raise. We can look at pulse pressure variation. If we have echocardiogram, we can look at his heart. What if he's fluid resuscitated? What would you do next? Simon says to add a second vasopressor. I agree with him. I would add a second vasopressor at this time. If you know he's been adequately fluid resuscitated, and again, it's not one resuscitation and stop. Sometimes you have to resuscitate, but you use your dynamic measures to determine if he's adequately filled. And if he is, and you're on pressors, then we would need to add a second agent. So let's go to the orange box. Match the clinical scenario on the left with the correct vasopressor on the right. For septic shock, what is the preferred first line agent? Noradrenaline. You have septic shock and you're on noradrenaline infusion at 0.5 mics per kg per minute. What would you add? Vasopressin. Septic shock, but noradrenaline is not available. What can you add instead? You can add adrenaline or dopamine. Okay, septic shock, despite noradrenaline and vasopressin, what can you add? I'd add steroids. I didn't put that on there, but we can also add epinephrine. Septic shock with cardiac dysfunction, what would you add? What helps with cardiac squeeze? Dobutamine, yes. Right. You can also add an epinephrine, but if you're adding epinephrine, you can do it alone and see if that helps. Good, very good. Okay, next, the recommendation.
Yes, let's see the recommendation number 37. So for adults with septic shock, we recommend using norepinephrine as the first line agent over the vasopressin.
Okay.
So with a remark that in settings where norepinephrine is not available, epinephrine or dopamine can be used as an alternative, but we encourage effort to improve the availability of norepinephrine. So the recommendation number 38 is that state that for adults with septic shock on norepinephrine with inadequate MAP level, we suggest adding vasopressin instead of escalating to dose of norepinephrine where it's available, because like in Rwanda, in most settings, we really don't have it. So with the remark that in our practice, vasopressin is usually started when the dose of norepinephrine is in the range of 0.25 to 0.5 mics per kg per minute. So recommendation number 39 stated that for adults with septic shock and inadequate MAP level, despite norepinephrine and the vasopressin, we suggest adding epinephrine. So the recommendation number 40 for adults with septic shock, we suggest against using vasopressin.
Yeah, we don't have terlipressin, so we can. Recommendation 40 is not as important.
Yeah.
Okay. Who's the next?
us.
Okay, so what monitors will you use for Mr. G, and how often will you check his vital signs? Which monitors do you want to use on this patient? Gideon, would you pick up the microphone and say it out loud? Cardiac monitoring, what else? Blood pressure, good. Pulse oximetry, wonderful. Okay, how often will you check his vital signs? He's now in septic shock on 2 pressors, on high oxygen levels. You want to check him once a day? Continuous. I like that answer. Let's do it continuous. Jean deduce is every 5. I agree with that. Thank you, Jadot. What kind of IV access is ideal for Mr. G? A central venous catheter. Why? What's the indication for central venous catheter placement in this patient? Vasopressors. That's right. Central line access is not available in your setting. What size IV will you start and where will you put it? So we'll go to the recommendations because the answer is in the recommendations.
All right, so recommendation number 43 for adult with septic shock, we suggest using invasive monitoring of arterial blood pressure over non-invasive monitoring as soon as practical and if resources are available. So number 44 for adult with septic shock, we suggest starting vasopressor preferably to restore MAP rather than delaying initiation until a central venous access is secured. With a remark that when using vasopressor preferably, they should be administered only for a short period of time and intervene in or proximal to the antecubital fossa. Why is that, Anna?
Yeah, that's great. And it seems like a lot of people in the chat box are answering correctly. But if you don't have a central line, you need a well-running IV that's proximal. So in the antecubital fossa or closer to the heart. And the reason is if you're running high doses of vasopressors peripherally, the complication is extravagation. Your IV fails and your pressors go into subcutaneous tissue and cause ischemia and damage to the tissues. So it's really important that your IV is very well placed and running very easily. So if you can get an 18 gauge or larger and put it in the antecubital fossa or more proximal, there's a greater guarantee that that IV is going to run well versus a small 22 gauge in the back of the hand or something like that. Okay, does that make sense? So the danger of running vasopressors into a peripheral IV is extravasation with tissue necrosis. That's why we prefer the central line. But if that's not available, you can run peripherally, ideally only for 24 to 48 hours so that you can get a central line. The central line should be run.
Thank you, Anna. So let us continue with our case. So our patient is now in the ICU, and the ICU nurse calls you because Mr. G has emesis with a large volume of bilious liquid. He is now short of breath and requiring 15 liters per minute by non-breather mask. She also stated the nurse stated that the laboratory called to report additional investigation data. You asked for repeat chest X-ray to be performed immediately after the at the bedside. So you arrive at the ICU you find that Mr. G he's now on 15 liters per minute on oxygen by facial mask, but short of breath, ill appearing, and with increased work of breathing. So under noradrenaline infusion at 0.5 mics per kg per minute, and vasopressin is infusing at 0.03 units per minute.
Okay, So this is actually the completion of part one. Just to recap what we discussed, we talked about initial presentation, we talked about resuscitation, we talked about source control and identifying the source of sepsis. We talked about identifying it early and responding early, having close monitoring. We talked about transferring to a higher level of care, whether that's in your own facility or to a different facility and the considerations around that. We talked about starting antibiotics and whether someone is is at risk for MRSA, multi-drug resistant bacteria, or fungal infections. We talked about starting antibiotics quickly. We talked about prolonged infusions of beta-lactam antibiotics. And then we talked about the hour one bundle, fluid resuscitation, et cetera. Let's come back at 11:15. So we're going to take a 15-minute break. For those of you joining us online, thank you so much for being with us, and we'll resume the presentation at 11:15 for a tea break. Thank you.